UCSF is the birthplace of fetal surgery, and we're really excited to be leading the way in the evolution of fetal surgery to encompass more medical therapies for fetuses with genetic diseases. We tested the idea of giving this medication before birth in mice. And when it worked very well, we were able to get permission from the FDA to conduct a clinical trial in 10 patients with similar metabolic conditions. Some of these conditions lead to the development of symptoms in multiple organ systems after birth, and in some cases, those symptoms are not reversible. So we're hoping that earlier treatment can result in better outcomes.
Isla is our little toddler, toddling around. She is getting into everything at home, walking around all the time. Only time she rests is when she wants to eat or when she gets hurt. She needs a little bit of soothing. She's keeping us very busy.
Isla has Pompe disease, which is a genetic disorder. It affects her muscles all over her body.
Hey. When we were having Isla, we didn't know she'd be able to walk. We didn't know she'd be able to talk. We didn't know she'd be able to eat. We didn't know she'd be able to laugh, right? So as she hit each of these milestones, we continue to kind of be amazed at her progress.
When the Canadian family was diagnosed, they wanted to participate in the clinical trial, but they weren't able to fly back and forth to San Francisco during COVID. So we shared the protocol with our colleagues in Canada, and they were able to get local approval to try this strategy. And we've been working together to take care of this family, and we're thrilled about the good outcome in this situation. When we give the enzyme before birth, it can more easily get into the brain before the blood-brain barrier has closed. In this situation, we were able to clearly see that with the in utero therapy, this child did not develop any heart disease and now has a normal cardiac outcome, normal motor function, and normal developmental function. We learned from this family that it's possible to diagnose and treat a fetus with infantile Pompe before birth, and we're excited to continue this clinical trial to get information on similar conditions. Maya is the first patient that we've enrolled here at UCSF for this clinical trial. She is carrying a fetus with Hunter syndrome, which is a disease that runs in families and in her family.
My baby brother, he also has Hunter syndrome. So it's been a lot of research in my family that we've looked over and looked into different treatments. Always have hope, because when we first got his diagnosis that he does have Hunter's, that I am a carrier, it was a very emotional time. We had our tears.
I wanted to give him a fighting chance because the previous year we had a miscarriage with twins, actually. So we were young, but we were still hurt, so we didn't know how to feel.
At first I was nervous. I'm not a fan of doctors in the hospital, but Dr. MacKenzie, she's great. It feels like a family. I'm hoping that these procedures and the enzyme replacement allows my son to say mama, daddy. My brother has not said mama, daddy, or sister.
These are, of course, rare genetic diseases, and it's even more rare to have a fetal diagnosis of this condition. But we feel fortunate that we have enrolled and treated now 2 patients, and we're hoping that as patients hear more about this clinical trial, that they will seek us out for more information about participating. Good morning, everyone, and welcome to our workshop on prenatal enzyme replacement therapy for lysosomal storage disorders. My name is Tippi MacKenzie. I'm a pediatric and fetal surgeon here at UCSF and the principal investigator of this trial. So just a small overview of today's program. As you've seen, we're mainly going to share the rationale for fetal therapies, the rationale for in utero enzyme replacement therapy, and how we got here, some of the preclinical data and the stages of getting an IND approval to perform this phase 1 clinical trial. We'll share the results of the first 3 patients treated, as well as the nuts and bolts of how we handle referrals and travel to UCSF. Next slide. So we're representing an enormous team, a multidisciplinary team An enormous number of people have contributed to this project from its inception to the current day. And I'd like to introduce my co-speakers and organizers. Dr. Paul Harmatz is a professor of pediatrics here at UCSF and is the co-PI of this trial. Emma Canepa is our program manager and clinical trials coordinator. Val Doherty is the program manager of the Center for Maternal-Fetal Precision Medicine, which is running this trial and our other molecular therapies trials. Dr. Ekosh Herzeg is a fetal surgeon from Germany and a senior research fellow in the center. Billy Liagnoglu is our genetic counselor, and Marissa Schwab is a UCSF surgery resident who's ran the process of obtaining the IND. And we're also representing an extended team of collaborators, Dr. Cohen, Kishnani, and Bali from Duke University, Dr. Borges, who's a research fellow in my lab at UCSF, Dr. Gonzalez, the fetal surgery who performs all of our in utero procedures, Dr. Gelb at Washington University, who has been enormously helpful in the assays, and Dr. Sarah Young from Duke University. Some of these people will be speaking today. We're going to present for about 45 minutes and leave lots of time for questions and discussions. I'd ask you to just mute your camera and you can, or mute your microphone. You can keep your camera on or off during the presentation. And if you have questions during the presentation, please type them in the chat and we'll present them later. So I'll start off by talking about the rationale and the preclinical studies for in utero enzyme replacement therapy. I'm really enormously lucky to work at UCSF, which is the birthplace of fetal surgery. Fetal surgery started with Dr. Michael Harrison at UCSF in the 1980s. And today we and others all over the world, some of you probably, perform a number of different fetal interventions, some of which are shown here. So we can do open fetal surgery, most commonly for things like spina bifida. We can do fetoscopic surgeries, most commonly for twin problems, as well as catheter-based interventions to drain fluid collections. Fetal blood transfusions, which involve placing a needle into the umbilical vein, have actually been around since the 1960s to treat RH incompatibility between the mother and the fetus. And it's this commonly performed and safe access procedure that we can use for what we're calling these fetal molecular therapies, such as stem cell transplantation, which is a different clinical trial, enzyme replacement therapy, obviously the topic of this trial, and perhaps in the future, somatic cell gene therapy or editing. Next slide. And this is an incredible time to be thinking about these fetal molecular therapies because we're living in a really unique period in history where we are witnessing the convergence of three separate but related fields. That of fetal therapy, which of course, as I said, is performed all over the world. Prenatal diagnosis, as you know, has really taken off, and we can now perform whole exome or whole genome sequencing of fetuses in utero, a program that is performed by my colleagues, Dr. Norton and Sparks at UCSF. And the molecular therapies, of course, continue to advance. And so we have the opportunity to treat many single gene disorders, some of which are shown on the slide. And of course, lysosomal storage diseases are among the top on the list. Next slide, please. So you might ask, why not wait until birth? And the most important answer and the reason that fetal surgery was invented in the first place for anatomic conditions is that we want to treat or prevent the onset of irreversible organ damage. And the fetal environment offers a number of other advantages, such as a permeable blood-brain barrier. There's a unique immune system. Some of the stem cell populations are more accessible. And of course, the small fetal size allows us to use a tiny amount of the material. Next slide. And the rationale specifically for lysosomal storage disorders, I think, is quite compelling. As you all know, these are genetic diseases with deficiencies in critical lysosomal enzymes. Some of them present with hydrops, which is a premorbid condition in the fetus manifested by pleural effusions and ascites. And they can be treated with recombinant enzyme replacement therapy after birth. But we thought that the rationale for prenatal therapy in this case could be, for example, to prevent fetal demise, especially for fetuses with high drops, such as those with MPS 7. We can potentially induce tolerance to the missing enzyme, which of course can be an issue postnatally, patients developing allergic reactions to the recombinant protein. We can potentially deliver enzymes to the brain and improve neurologic outcomes. And again, most importantly, prevent the ongoing organ damage to organs such as the heart and the liver before birth. Next slide. So we, of course, have a translational research arm, and we wanted to try this strategy in mice. So we did some experiments in my lab several years ago, and these were published in 2020 in Science Translational Medicine. What we did was to breed MPS 7 mice and inject them in utero with a recombinant enzyme, which we obtained from Ultragenics. And then the half-life of the enzyme is only 2 weeks, as you know, and so we did some postnatal enzyme boosts. And we were happy to see that the experiment worked very well. So first, that we prevented fetal demise and improved survival. We improved histology, as you see in the top slides there, where in the untreated MPS 7 animal, you see those lysosomal accumulations, the white circles, which you don't see in the treated animals. The MPS 7 mice have shorter bones, and the in utero therapy was able to improve bone length. So in these slides, the red femur is the wild type animal. The blue femur is the untreated MPS 7 animal, and the green is the treated MPS 7 animal. And you can see the bone length is higher in the graph. We were able to induce tolerance also in brain penetration, which I'll go into in a little bit more detail. Next slide. So the fetus has a unique immune system, which is really wired for tolerance. And this is an area of fascinating research that's been going on since the 1950s. And it appears that in humans, actually, the T cells that are important for fighting infections and fighting foreign proteins are actually more programmed to turn into regulatory T cells, which actually induce tolerance to new proteins, with the idea that a fetus is really only seeing proteins that it should be tolerating, such as its own proteins or the mother's proteins. And when we did the experiment in the MPS 7 animals that I showed in the previous slide, we showed very clearly that if we gave the enzyme in utero, which is shown here in the green bars, that the animals developed much lower levels of antibodies compared to those animals that hadn't seen the enzyme before birth and were sensitized later birth, and that's the red bar, or animals that saw the enzyme for the first time after birth, which is the purple bars. So we're encouraged that this might be something that is beneficial to patients in the clinical trial. Next slide. There's also a unique blood-brain barrier in the fetus, which appears to be more permeable. And this is an area of active research in my lab at UCSF in collaboration with Dr. Betsy Crouch. In these animals, with the MPS 7 animals, when we gave the enzyme, in what you see in the graph there is that the animals that had the in utero therapy, again shown in the green, had decreased microglial activation, which is a marker of brain inflammation. And what you're seeing in the pictures is that when we gave cells in utero, those stem cells were able to go into the brain and become microglia, which can be sort of a permanent source of the missing enzyme. Next slide. So although there is a lot of promise in this animal model, we also think about some of the risks and benefits of doing this in a human fetus. And I think the most important thing we need to think about is the procedural risk, because unlike fetal surgery for anatomic conditions, these are genetic diseases, and we're doing a procedure often in a fetus who doesn't otherwise need the procedure. So the technical expertise is really critical. And as I mentioned, Dr. Juan Gonzalez is the fetal surgeon at our center who does all of our in utero transfusions. And before starting this trial, we actually audited the last 10 years of operations to make sure that we had an excellent safety profile for offering this at UCSF. The umbilical vein injections are performed worldwide, and they're done in an ultrasound-guided manner, which you see in the pictures here with the ultrasound probe. There's Dr. Gonzalez holding the needle that's going into the umbilical vein as shown in the ultrasound image. The inexperienced hands, there should be a less than 5% risk of all complications such as bleeding, and the overall risk of fetal demise should be below or around 1%. This is one reason why this, for the first 10 patients, we would like this to be a single site clinical trial at UCSF so that we can control at least the procedural risk while we're monitoring other safety and efficacy data. And we hope that when this is disseminated to other centers around the world, that it be done only by experienced MFMs with a proven high safety record with these procedures. Next slide.
So it all started with one patient in September 2019. A carrier mother was diagnosed with a fetus with mucopolysaccharidosis type 7 or MPS 7 by chorionic villus sampling. Her family history is notable for a prior child who had been diagnosed after birth and treated with enzyme replacement therapy until she unfortunately passed away at 10 months of age. So when the patient was found to have worsening high drops at 23 weeks gestation, her family actually asked to be referred to UCSF for fetal therapy because they had heard that this was something that Dr. MacKenzie's lab was working on. Next slide, please. And we successfully obtained FDA approval to treat the fetus. However, 2 days after approval, as we were setting up flights for the patient to travel from the East Coast and planning for the in utero therapy in the coming days, the patient underwent a repeat ultrasound, which showed severe anhydramnios due to fetal renal failure. This, in concert with concerns for impending preterm labor and the patient's entire social support flying across the country, led us to decide not to offer this patient fetal enzyme replacement therapy. But this patient's case inspired us to start designing a clinical trial to treat others just like this family. Next slide. As you can imagine, for this technique, a specialized fetal treatment is critical. At UCSF, we're very fortunate to have a fetal treatment center that consists of a wide variety of providers, from maternal-fetal providers and pediatric surgeons to genetic counselors, bioethicists, regulatory affairs specialists, and many others. Next slide. As we were developing the trial, it was crucial to engage the patient community and understand patients' and parents' attitudes towards fetal therapies and fetal trials. We wanted to know if this was something they would even be interested in. So we partnered with several patient advocacy groups, including the National MPS Society, around the world, and we're really overwhelmed by the enthusiasm and encouragement that we received about fetal therapy in our trial, some of which are examples that you can see here. Next slide. And as part of our community partnership, we surveyed almost 200 parents and patients with lysosomal storage diseases regarding their attitudes towards fetal therapies and trials. So when we asked our respondents about the likelihood of ending a future pregnancy that was affected by a lysosomal storage disease, 60% said that they were unlikely to end a future affected pregnancy. Then when we asked them about fetal enzyme replacement therapy and their likelihood of choosing fetal enzyme replacement therapy if this was an established therapy, 71% of respondents said that they were likely. When we framed it as more of their likelihood to enroll in a phase 1 trial, so looking at safety and efficacy for fetal enzyme replacement therapy, there's still 60% of respondents who are likely to enroll. Next slide. So this is the timeline of the journey to gain FDA approval for this trial. The mouse experiments that Dr. MacKenzie talked about took about 3 years and ended in 2019. And then that patient case that I talked about, for which we received the single fetus IND, was in September 2019. And within a year after that, we received IND approval to open the clinical trial, which was then officially opened in April of 2021. So I'd now like to turn it over to Billy Lianoglu, our exceptional genetic counselor. Thank you very much.
Thanks, Marissa. I'm going to go over the clinical trial timeline and workflow for those patients interested in participating in providers when you have a patient appropriate. First, inclusion criteria includes a confirmed prenatal diagnosis, either by chorionic villus sampling or amniocentesis, of 8 lysosomal storage diseases. These are all conditions in which there was a FDA-approved postnatal standard recombinant enzyme available, enzyme replacement therapy available for, and these conditions include MPS 1, MPS 2, MPS 4A, MPS 6, 7, infantile-onset Pompe, neuronopathic Gaucher, which includes type 2 and 3, and Wolman disease. After a patient has a confirmed diagnosis, we would offer them an evaluation. Certainly, if you have a patient known to be at risk early in pregnancy, we'd encourage you to still reach out to us and begin engagement with the family so they can understand the potential opportunities regarding participation in the study. But the confirmed diagnosis is when the evaluation would take place. We would initiate enzyme replacement therapy in utero between 18 and 35 weeks gestation. And this replacement therapy would take place every 2 weeks in the pregnancy. We realize that many of these treatments are weekly postnatally, but given the potential risks from the in utero enzyme administration, we space that out slightly to every 2 weeks. After babies are born, they would commit to pursuing standard of care enzyme replacement therapy and or hematopoietic stem cell replacement, stem cell treatment, if appropriate for that condition. And then the goal is to follow these babies into their early childhood. So we follow through the first 5 years of life. And that follow-up includes disease-specific outcomes that we're measuring in addition to neurodevelopmental outcomes. We're also evaluating remotely those neurodevelopmental outcomes and have a great partnership with our pediatric neurologist, Dr. Dawn Gano. The outcomes for the clinical trial being phase 1 primarily are safety, both safety for the mother and safety for the fetus, and feasibility to be able to administer enzyme repeatedly throughout gestation. Secondary outcomes include measurement of biomarkers, including the evaluation of decreasing GAGs in the pregnancy and also postnatally. So at each enzyme administration in utero, prior to the enzyme administration, we remove a small amount of cord blood to measure GAGs, and also we remove a small amount of amniotic fluid. This is to also assess trough levels of the enzyme throughout gestation, making sure that we're aiming for a therapeutic dose. Tolerance to enzyme replacement therapy is measured, so there'll be some evaluations looking at anti-drug antibodies, and then again, the long-term outcomes. Next slide, please. For patients that are interested, again, please feel free to connect us with the patients early prior to prenatal diagnosis. We start conversations using remote consultation through Zoom or telehealth. When the family is referred, we get to know them better, get to understand their family experience by reviewing their family history, understanding the outcomes of those in the family that have also been affected with the disease if there is a family history. We always discuss non-directively all options in pregnancy that can include the opportunity to pursue pregnancy termination, standard of care, including initiation of treatment after delivery, and then in utero enzyme replacement therapy and the potential goals of our clinical trial and the potential risks as well, and how this could impact postnatal care. So there are a whole landscape of emerging therapies for this area of lysosomal storage diseases, and Dr. Harmatz is going to talk more about the emerging therapies, including gene therapies. And for our patients, a common question had been if involvement in our clinical trial would impact their eligibility for these postnatal clinical trials that may be disease modifying. And we have engaged industry sponsors related to the work that we're doing to understand our outcomes and their goals and outcomes that they're measuring in their study participants, and have been reassured that they would welcome patients that have participated in our study to their study. And we continue to engage those industry sponsors. At UCSF, we have a broad infrastructure to support patients that come from all over the world. And that includes in-person and video interpreters. For the second patient that we treated here at UCSF, the mother was Urdu speaking. We had a tablet in the OR at each procedure where she had someone Urdu speaking at the top of her head, so that everything that was being done in the OR, all of the consultations prior to the procedure and throughout her whole admissions, she had someone that was competent in speaking her language, and she understood everything that was happening when it was happening. And we also have an interfaith chaplain spiritual care system. So these are stressful times for families. And if they would seek support through a chaplain, we have that available for any faith. Next slide, please. For those patients that are identified to potentially be eligible for our clinical trial, with their permission, we would ask that you contact our team and forward all appropriate medical records, including records pertaining to prior affected family members, so we can clearly understand the outcome in that family for their genotype. When we have medical records to review and a potential eligible family, we will convene our enrollment advisory board, and our team will review the records in combination with the enrollment advisory board. This is really important because we want to make sure that we're enrolling the right patient for this clinical trial and those with the more severe phenotypes. So we will both review their family medical records in addition to the literature to understand the genomic variants that are observed in this patient, and that it's consistent with the phenotype that we feel is appropriate for eligibility. And then we will organize a Zoom consultation to review with the family their experience, the rationale behind the clinical trial, the discussions from our enrollment advisory boards, and also non-directively counsel regarding all options, including pregnancy termination, standard of care, and enrollment in the in utero enzyme replacement therapy clinical trial. Next. If a family is interested in learning more about the study and understanding their eligibility, we would welcome having them come to UCSF for evaluation. It's important to understand that coming to UCSF for evaluation is not a commitment to enroll in the clinical trial. It's just a commitment to be evaluated, learn more about eligibility, and learn more about the study. If for any reason the family is excluded or choose not to enroll, they could continue standard of care postnatal management. If they choose to enroll in the clinical trial, we would initiate enzyme infusions beginning at 18 weeks up until 35 weeks gestation. Patients would have enzyme infusions every 2 weeks, and they could either return to San Francisco for each infusion, and we would coordinate travel, and Emma's going to discuss that next, or they could relocate to San Francisco. At each enzyme infusion, we measure different biomarkers, including those that I reviewed earlier, and these are both for safety and endpoints. In addition to our growing interest and commitment to improving our understanding of variations observed in these genes, so we're working together with Dr. Michael Gelb and Sarah Young to understand the norms of the GAG levels in amniotic fluid, so that we can better define, when seeing a variant of uncertain significance, the likelihood of it being associated with severe disease. And again, the safety, the endpoints that we've discussed, including the safety of repeated infusions, safety to the mother and child, measuring anti-drug antibodies in their serum, and the feasibility of enrolling 10 patients and administering these medications. Emma's going to now discuss the logistics of how we bring patients and the coordination of the clinical trial once they're here.
Hi, everyone. Thanks for joining. So I'd like to start by really encouraging folks to contact us anytime regarding these referrals. We have a lot to prepare for each one of these potential participants, and so the more time we have, the better. And we would really love to hear from you as soon as you suspect a diagnosis, and our team can even help facilitate diagnosis confirmation if that's something that would be helpful for your local team. So once a family decides that they want to come to San Francisco for evaluation, I'll actually be the one who arranges all of their travel to and lodging in San Francisco. And along with Billy, will be one of their main support people for logistics and any needs while they're here in San Francisco. So once a family says like, yes, we're ready to get on a plane, we will go ahead and arrange their flights for them. We will arrange their lodging, and any, if there are any specific needs for our international referrals, we make sure that those all go along fine too. And then Billy and I also schedule their many screening visits, as well as all of their treatment visits if they decide to move forward to that part of the study. And again, I do want to stress that families are not promising to participate in the study by coming to San Francisco. We have funding for any interested family to come and meet the team in person. We feel like that's a really important part of a family deciding to entrust their care to us. So just like any other clinical trial, they can, come to San Francisco, but decide to withdraw their consent and participation at any time. I do want to point out that all study-related costs are covered by the trial. So we will pay for flights, lodging, food, any taxis or ride shares that the families need, any other miscellaneous travel-related costs. Those are all covered under the study. And we do we do pay for both the participant and their caregiver to come out to San Francisco. And in the event that the family has any young children that need to accompany them, we also will cover for those young children to come out. And of course, we also cover all study-related procedures and care. So those are all paid for by the trial. Looking forward to delivery and postnatal care and enzyme replacement therapy. While the postnatal care is coordinated and performed by the local provider and covered by insurance, our team can help facilitate the referral for postnatal enzyme replacement therapy. And we really do everything we can to make sure that postnatal ERT is available for our families at home. We especially know that there can be some delays in insurance approval for that first dose of enzyme replacement therapy after birth. And our team has moved mountains to help ensure that that crucial first dose is able to be administered in a timely manner for our participants. So we can also help support local teams in that way. Next slide, please. I'd love to go over some special considerations for our international participants. I'm sure you're sensing a theme here. Time is really of the essence. So please contact us as early as possible. There are additional coordination requirements for international patients. We work very closely with our international office for each of these referrals. And so the sooner we know about a potential participant, the better. Of course, families will need passports and visas to come to the United States. So it's super helpful if we can confirm whether or not the family has that paperwork, as soon as possible. That's going to be one of the first questions that we ask you if you were to refer an international patient to us. If the family does need to apply for an urgent passport, urgent visa, we can help facilitate medical letters for those requests if needed. We do ask that families stay in San Francisco for the duration of their pregnancy. We really want to try and control for as many variables as possible. And our team is most comfortable if families stay close during this time. And so because of that, it's going to be especially important for international families to consider purchasing traveler's insurance. In the event that the participant or their caregiver might need any care that's unrelated to the study during the 3-ish months that they would be here in San Francisco, it would be really important for them to have that medical coverage here in the United States. And so with that, I will hand it back to Dr. Tippi MacKenzie, who's going to discuss the case review for infantile-onset Pompe disease.
Thank you so much, Emma. Yes, I'd like to review the first patient that was ever treated with in utero enzyme replacement therapy as a collaboration between our center, our Canadian colleagues, and Duke. We recently published this case study in the New England Journal of Medicine in December of 2022, and the reference is there. This is a family in which the parents were carriers for the given mutation of CRIM-negative infantile-onset Pompe disease, and they had had several affected pregnancies, and we were consulted for their fourth affected pregnancy. You can see sibling number 1, which is the proband, was diagnosed at 8 months and had immune reactions to the enzyme and died at 29 months. And sibling number 2 was prenatally diagnosed, so we were able to have some of the prenatal data there to compare with. Had palliative care only after birth and died at 8 months. And the current patient was referred for fetal therapy. And the rationale for in utero enzyme replacement therapy in this family was the known severe phenotype in this family, where they had early onset cardiomyopathy. And as you probably know, the patients with CRIM-negative IOPD have particular issues with immune reactions to the enzyme. And so we thought perhaps there could be an immune benefit. Next slide. So as I mentioned, and you saw in the video, this was a wonderful collaboration between our team, the Canadian team led by Dr. Pranesh Chakrabarty, who is the pediatric geneticist who had been taking care of the family for years, as well as Karen Funky Fung, who's the MFM who ended up performing the infusions, as well as our colleagues at Duke, who are, of course, the experts at Pompe disease under the leadership of Dr. Kishnani, and colleagues at the University of Washington, led by Michael Gelb, to help us understand the enzyme trough levels and biomarkers. Next slide. So when the patient was referred to us, we did a Zoom telehealth consultation, as Billy mentioned, and did non-directive counseling with this family about all the options of the pregnancy. They wanted to continue with the pregnancy, but it was the height of COVID in 2020, so they weren't able to fly to San Francisco. And so our colleagues in Canada were able to give the infusions every 2 weeks, starting at just before 25 weeks, and they were able to give 6 doses until the baby was delivered at term. She's now doing well. She's 18 months old and has normal cardiac function, motor function, and developmental milestones. Next slide. The most obvious benefit of the in utero enzyme replacement therapy was in preventing cardiac hypertrophy. In this slide, I'm showing you the fetal echocardiogram images of sibling number 2, who was prenatally diagnosed but untreated. And you can see that at 34 weeks gestation, there's already thickening of the ventricular septum between the right and the left ventricle, shown there, with a Z-score of 7. Whereas sibling number 3, which had been in utero treated several doses by 34 weeks, had a completely normal ventricular septum with a Z-score of 0.6. Next slide. When we looked at the cardiac function by echocardiogram after birth, measuring the left ventricular mass index, this patient is shown in green compared to the siblings, which are shown in purple and red. You can see that the LVMI was normal for this sibling throughout the periods that we measured. And we were also lucky with Dr. Kishnani's cohort to compare this patient to a cohort of 4 other CRIM-negative patients diagnosed on newborn screen who started treatment immediately after birth. And you can see a number of those patients started out with a higher LVMI score. Those are the patients in gray. Next patient. Postnatally, we also looked at creatine kinase levels, again, comparing to that CRIM-negative newborn screening cohort. And you can see our patient had normal CK levels at birth and throughout the first year of life. And again, compared to those 4 patients, 2 of whom had motor deficits such as central hypotonia and delayed milestones, our patient had normal AIMS scores, normal CHOP and 10 scores, and walked independently before 12 months. Next slide. We also have been measuring biomarkers in amniotic fluid and urine. As Billy mentioned, this is one of the things that's a bit more exploratory, and we're learning a lot more about amniotic fluid GAG levels, which change over gestation. So we're comparing to healthy control amniotic fluid. So on the left slide there, you see the GLIC4 levels in amniotic fluid that are low and rise naturally in all of the patients we looked, in addition to healthy controls. So we definitely need more data points there. And in postnatal urine, the measured GLIC4 levels were generally on the low end of the other CRIM-negative patients and have normalized in the period of time after birth. Next slide. As I mentioned, we were wondering whether the in utero therapy would help with tolerance induction. Because CRIM-negative IOPD is so problematic for immune reactions to the enzyme, we gave the standard immune tolerance induction under Dr. Kishnani's guidance after birth. And you can see that we're measuring the in utero development of antibodies, and this patient had some hint of developing antibodies before birth. But with the postnatal immune tolerance induction, these came down rapidly. Next slide. And when we compare the antibody development and resolution in this patient to the previous sibling, which is the proband shown in the other graph, you can see that the previous sibling had higher levels of antibodies that lasted longer and required a full second repeated course of immune tolerance induction. Next slide. So in summary, we showed that this was a safe administration of 6 doses of in utero therapy with a notable improvement in the predicted hypertrophic cardiomyopathy, as well as improvement compared to other CRIM-negative IOPD patients treated after birth in creatine kinase levels and motor function. We did see low titer antibodies, which resolved quickly. And as Dr. Hetzeg will show you later, we also saw avoidance of placental glycogen deposits.
It's my pleasure to join this really superb team, and I appreciate many of the friends who called in to learn about this really unique therapy. I can emphasize this comes at a perfect time after 30 years of development of enzyme replacement therapy for these 8 diseases, and recognition and improvement of stem cell transplant as the treatment of choice for MPS I. So here we have a treatment that probably is a bridge for disease we know that starts in utero to a long-lasting, lifelong or life-lasting therapy that occurs after birth. So see it as a transition, but emphasize that in this study, the focus is on safety and feasibility, and you can see how much has been learned from the in utero procedures and assays that have been developed by Sarah Young, Michael Gelb, to help look at substrate accumulation, enzyme levels in utero, antibody development. So it is coming at a perfect time. It's a partnership between a very good set of research group and industry who have worked so hard to bring these therapies to us. So we probably had the perfect patient, maybe the highest risk patient, come first with a Pompe disease because of the early onset of disease in utero and severe disease as a neonate. So it's the easiest to see efficacy effects. It also could have been the most risky with possible well-known antibody development and significant toxicity from these antibodies. So we were fortunate with this patient, and we hope that we can have more of these patients so we have an N greater than 1. You can see from the fact we have 10 patients, 8 diseases, this is really safety efficacy, not safety, feasibility, not efficacy. So as Billy already mentioned, Emma mentioned, described, that we're really postnatally focused on looking at whether we have modified antibody development, induced tolerance. This would potentially affect long-term response to enzyme therapy or even transplant after delivery. We as well are measuring accumulation of storage material, GAGs for the MPS, other storage material or markers of toxicity in the other diseases, and functional endpoints. You saw the very clear demonstrations of cardiac mobility in the patient with infantile-onset Pompe disease. And there are a number of exploratory endpoints, particularly focused on looking at the immune response in the different diseases. Next slide. It sounds like a very complicated protocol post-delivery, but emphasize that our main goal is to provide optimal standard of care. So each disease is treated in a possibly different fashion, different enzyme, immune tolerance induction with Pompe disease, stem cell transplant for MPS 1. So we don't try to interrupt what would be considered standard of care. We nestle in research visits, and we're now recognizing probably the most important time points to obtain blood and urine would be from cord blood. We now see that the 1 to 2 day dry blood spot is really helpful, and it can be correlated with what the state labs and the screening labs look like on a standard basis. 3-month visit is thought to be key, and then a yearly visit for 5 years. So we're hoping to focus on those time points and obtain as much information as we can in a standard fashion. Would like to insert an extra time point if we're making a major therapy transition, such as moving to stem cell transplant or beginning a new enzyme gene therapy. This would be a good time to have final samples before we have a significant impact from the new therapy. Next slide. On the left, I've outlined some of the new treatment strategies that are under development. There are many categories. I won't go through each of the categories. We have 5 approved, FDA-approved enzyme therapies for MPS. We have approved therapies for Wolman, Gaucher, and Pompe disease. But there are continuous improvements in enzyme with studies. Stem cell transplant has evolved. We have many studies on looking at intrathecal or ICV injection, intracerebroventricular injection, ERT. But I'll focus just a little more attention on the new blood-brain barrier penetration proteins and gene therapies. Emphasize that this protocol does not exclude use of these experimental therapies. So we hope we can partner these patients to us, at least on a referral basis, to studies that they might be interested in pursuing. So the clinical trials for the blood-brain barrier proteins, at this point, there are 2 major companies looking at developing fusion proteins that have the ability to penetrate the blood-brain barrier. JCR is one, Denali is the second. They're both in phase 3 trial with their respective enzymes. We're hoping it moves quickly. We expect there'll be really life-changing therapies coming from either one or both of these trials. And if you look at the pipeline, they have both MPS 1, 2, 3, which we don't have in this trial, and other lysosomal storage diseases included in the pipeline. So we're really excited about this direction of enzyme replacement therapy. Next slide. And this final look just shows you that the rapid progression of development of gene therapy for the different MPS and hopefully the other lysosomal storage diseases that we have in the study. You can see that there are both AAV direct administration, either IV or in the central nervous system, or ex vivo gene therapies where the stem cells are modified with gene editing and then returned to the patient. Both are very exciting directions. They're very active therapies in development for MPS 1 and 2 in particular, to try to hopefully treat the body and the brain effectively, and would be wonderful adjuncts to move to after fetal therapy. Next slide. I'd like to turn over back to Tippi to bring the meeting to a close, and again, thank everybody for their participation and interest.
Thank you so much, Paul, and thank you for your partnership. So in conclusion, this trial has only been ongoing for about 2 years, but we think that based on the experience that we've seen in these 3 patients, the in utero therapy was certainly well tolerated by mom and fetus. We have not seen any anti-drug antibodies in the mother, and with the exception of the low-level antibodies in the IOPD patient, we did not see anti-drug antibodies in the MPS 1 or 2 patients. We are seeing evidence of improved biomarkers, both in the amniotic fluid and in the urine and in the dried blood spot testing we're doing. And we see evidence of avoidance of the substrate accumulation in the placenta on the electron microscopes. Importantly, we have not seen, knock on wood, any complications after 14 in utero procedures combined, and there was no evidence of preterm labor. All of the patients had a full-term uncomplicated delivery. And we think that participation in this trial can also act as a bridge towards more definitive therapies. As Billy and Paul mentioned, we have been actively, counseling these patients and connecting them with the best available postnatal therapies. Next slide. So we'd love to partner with you if you would like to refer a patient or collaborate with our team. Our trial is open for enrollment. As mentioned, we have funding for the medical costs and travel for 8 additional patients. We are open for domestic and international patients and have a lot of experience now with our previous clinical trials on all of the arrangements. And, please contact us early. We can provide a telehealth consultation with the referring physicians as well as with the patient. We also have an open registry of prenatally diagnosed patients with lysosomal storage diseases so that we can continue to add to the knowledge bases of specific mutations in these rare diseases. And this is a picture of our 3rd patient. So in terms of more details for our international prospective registry, the inclusion criteria are the same inclusion criteria diseases for our ongoing clinical trial. And so if you have any patients to refer or families who might be interested, please contact Billy Leonoglu. Next slide. So at this point, I want to thank the enormous team of people who contribute to this, my partners and colleagues, both who had the opportunity to present today, as well as the larger village of people who make this possible. We're very excited by this trial. We thank the NIH for the funding, and we most specifically thank the families for their brave and generous participation in our research. And at this point, if you guys will stop sharing the slides, if people could turn on their cameras if you're able to, and just use the raise hand function if you would like to ask any questions. I'll start by reviewing the questions in the Q&A sessions. Let's see. So Alan Muir was asking about enzyme infusion into the mother. And as Billy responded, basically we're dosing this for a fetus. So even if any sneaks into the mother, which we expect would be a minuscule amount because we are infusing directly into the umbilical vein in the direction that it goes into the fetus and not the placenta. It would be tiny, but because this is a phase 1 trial, we are actively checking for antibody levels in the mothers, and we have not seen any anti-drug antibodies. We're not able to check any levels of the actual drug because, of course, the patients, the mothers are themselves making some of the enzyme. Then Ryan Colburn, could you start to study that through peak and trough enzyme activity testing in mothers? Yes, exactly. And so we're not able to do that because we are testing peak and trough activities. Well, we're testing peak trough activities in the mothers, but they're basically half the levels of normal because the mothers are carrier for these conditions. I should say that in monkey studies of other fetal therapies, such as prenatal gene therapy, any amount of the infusate that was given to the fetus reaching the mother is really minuscule. But it is something that we take very seriously, and which is why we're checking the antibody levels.
Tippi, with regard to Alan's first question, he's asking, could you also maybe infuse the mother with enzyme? The FDA has not approved maternal infusions for these. It's never been studied. Tippi might comment whether I would doubt much enzyme would cross the placenta to the baby in that setting.
Yeah, I see that. That is a great question. Dr. Bill Sly had done some beautiful work some years ago with a recombinant MPS 7 enzyme, beta-glucuronidase, that was conjugated to an IgG that was designed to cross the placenta. Unfortunately, that was a research study, and those modifications are not clinically available.
This is Sandra Dazzo, Tippi, very, very nice meeting you. This is an incredible work, and I want to congratulate you and the entire team that participated to this trial. Of course, I work on lysosomal storage diseases that are not included. So what my major goal would be, how feasible will be to include, for instance, registry for instance, glycoprotein storage diseases like galactosialidosis, who present with, for instance, hydrops fetalis, ascites, these type of things. So obvious of these type of features that obviously could be incredibly important to take into consideration for inclusion into this particular trial. The prerequisite, I believe, is that because of course you are treating patients, populations that are already have already FDA approval for ERT. So obviously this was an incredible endeavor and a very, very reassuring and encouraging set of studies. But I wonder how we can go ahead moving forward, because this could be such an incredible approach for so many of these kids.
I agree. Thank you so much for your comments. Yes, so for this trial, we had to go with enzymes that are already FDA approved. At UCSF, in my group and with collaborators, we're very interested in fetuses presenting with hydrops. And my colleague Teresa Sparks has an ongoing study of enrolling fetuses with hydrops for whole exome and whole genome sequencing. Billy is the genetic counselor involved in that study. So we would love to, partner with you and maybe talk offline about how your patients could participate. And then in the lab, we're actively trying to develop therapies that perhaps don't exist for these fetuses because they haven't necessarily been on the radar of people to try to develop therapies too. Yeah, so perhaps we can talk offline about how to partner. But yes, those other conditions presenting with hydrops is a very important research interest and long-term therapeutic goal for us.
Thank you very much. Thank you to all of you.
Thank you so much.
Tippi, there's also a question in. Oh, you see that, Paul.
Elsa Shapiro is asking, is there a future potential for using either the JCR or Denali fusion proteins, I assume in the infusing and transferring to the baby? I think this is a really intriguing idea, something that Tippi should pursue in the laboratory with either an MPS1 large animal or a MPS2 mouse that she could work with. But it is intriguing. I think it'll have to receive FDA approval, which is several years away, before it could be thought to, added to our list. But we're always, Tippi's looking at the list of new enzymes and considering whether additional diseases such as Niemann-Pick AB should be added to the protocol. So, but again, this is a proof of principle, and hopefully the structure of a network for a follow-up study that gets many more patients and more information would come after this as a goal of this first study.
Yes.
Paul,
okay.
Go ahead.
Oh, no, go ahead, please.
I was just responding to Paul. I think if you were to do, and these would have to be laboratory studies at this stage, studies of the Trojan horses, it would be actually interesting to look at it both from a fetal vein injection point of view and from direct administration to the mother. And I have a funny feeling that regulatory agencies would actually want to see both kinds of data eventually before allowing that to go into humans.
We can't hear you, Paul.
David's absolutely correct. It would be great to start in utero similar to the MPS 7 studies, and then move to asking whether mother could transport these proteins. I don't know how the mouse transferrin receptor would interact. That would require some more sophisticated model, but Denali and JCR have worked with these type of human knock-in, disease knockout type models. So great suggestion, Dave. I should mention again, David is with Takeda, was with Shire, was with TKT. Before that has been almost a 20-year, more than 20-year colleague. And, we've gotten tremendous support for industry. If I had to encourage the world out there, we would love to get MPS 7 hydrops. These are infants that are not sort of younger sibling in family disease groups, but would be de novo when any group suspects that it might be a hydrops and they're beginning to do evaluation. Please get in touch with Tippi and start the ball rolling. When we're in the 20-week range, the progression of the disease is so quick that it's hard to bring them in and consider therapy in this group.
Yeah, I really can't stress that enough. We have gotten a number of referrals where there was a delay in referring to us because of, awaiting amniocentesis results. And, we're never, we're always just happy to hear even from from clinicians, genetic counselors saying, here's a family in which both parents are carriers, they're pregnant again, and they're awaiting results. And that really allows us to get all our ducks in a row so that we can be ready for the referral, because, you know, often once we have the diagnosis, we have the initial telehealth consultation, it's already 20, 22, sometimes 24 weeks. And we've had families just get on the plane that night to come to San Francisco. And we'd love to sort of avoid that rush.
Yeah, absolutely. I mean, for many of these diseases, hydrops is the presenting sign. And, you know, over the years, I can recall a number of cases of MPS II presenting with hydrops, which ordinarily is not considered to be part of that group, but rare cases have presented that way. So I couldn't agree more. I mean, if there's hydrops, then there needs to be a consultation.
Paul Hillman is asking, do you have the ability to do genetic testing at your center? Absolutely. And Billy, do you want to address that?
Yeah, we do have a genomic medicine laboratory, and they are offering exome sequencing. And so potentially we could discuss with your teams if there's a need for detailed sequencing of a patient because of a concern for one of the conditions that we're treating. There was also a question in the chat regarding Morven Holik from Edinburgh. So thank you for joining us. And Dr. Juan Gonzalez from our team will be in Edinburgh in June for the International Society for Prenatal Diagnosis. So say hello to him then. Thank you for your compliment regarding the study. And the question is, outside of the study, what do you feel are the biggest barriers to any future wider rollout of such a strategy, i.e. prenatal diagnosis, access to appropriate medical care, etc.? You know, one thing about this clinical trial is we're utilizing an intervention that if there is a fetal therapy center established with their, they've put their stake in the ground, this is one of the interventions that they're able to do is in utero transfusions at a minimum. Prenatal diagnosis can certainly be complex, particularly in simplex cases where there isn't a known family history. With the emergence of expanded carrier screening, and we've looked at what's available, at least here in the US, most of the companies offering expanded carrier screening, if you look at their biggest panel, do include these conditions. And so certainly it's a consideration as an OB prenatal provider, how to screen your patients appropriately and the benefit of expanded carrier screening. And certainly patients often will comment on what is the value for me. And knowing that there's a potential intervention that might be available certainly is meaningful to families. And so considering which test you're offering and whether or not it includes conditions that have fetal therapy available is something that's important to consider when deciding which of the panels you want to offer your patients. So I think prenatal diagnosis is a challenge. Ascertainment of affected pregnancies is important, and harnessing what's available now with next generation sequencing and considering thoughtfully what to offer your patients a priori, preconception ideally, or early in the pregnancy is important in how you're screening and making diagnoses.
And just to add to that, the iFetus meeting, which is the International Fetal Transplantation and Immunology Society, which is a mouthful, but it is a niche group of people who care about fetal molecular therapies. Our annual meeting, which is organized by Anna David, thanks Anna for being on the call, is also in Edinburgh 2 days before the ISPD meeting. So feel free to come join us. One more question in the chat from Ana Flores was, are there other centers around the world that have a center for fetal medicine? Yeah, there are certainly many fetal surgery centers around the world. We're unique in doing these clinical trials of the fetal molecular therapies, and we're excited to complete the clinical trial so that we can have the safety and efficacy data that we're carefully controlling for all these patients. And we do anticipate that afterwards, this should be something that could be rolled out to people locally in their own countries. And Courtney, for writing in the Courtney, thank you for writing in the chat about our fellowship. So Dr. Hetzeg and Dr. Borges are our first two precision medicine fellows, who, as you can see, are really integrally involved in these projects. So if you know people who might be interested in applying, we're taking applications now for the next crop of fellows. Thank you all so much for attending. This presentation will be online, and we may have repeat versions just to make sure that we reach colleagues around the world who might be in completely different time zones. But please feel free to contact us if you have comments, questions, if you'd like to collaborate, and if you'd like to refer a patient to our registry or to our clinical trial. Thank you so much.
Thank you. It's really wonderful to see this moving forward. Congratulations, all of you.
Thank you.
Thank you very much again.
Thank you so much, and stay in touch, and really excited that a lot of you were interested to join our call, and we appreciate partnering with you. And thank you, Anna, for putting the link to iFetus. I'm sure we'll have presentations on this and other more exciting emerging therapies at the iFetus meeting that Anna is organizing in Edinburgh.